To err is human. To fail to learn is inexcusable. My name is Michael Sinnott, and in today's presentation, Dr. Chamindika Konara and I aim to address the gaps in healthcare's approach to the relationship between staff safety and patient safety. We will also share with you the practical tools that you can use to learn from past mistakes and to address hazards for the prevention of potential adverse events in the future. Case studies will be put forward to show what a systems-based approach looks like in clinical practice. Specifically, by the end of the session, we hope that you will firstly gain an understanding of systems-based approaches to managing patient and staff safety risks through both retrospective and prospective analysis. Learn to use tools for conducting an effective root cause analysis as part of retrospective analysis, and be able to utilise the CAPA, Corrective Action and Preventative Action framework, to ensure implementation of solutions determined by the root cause analysis, and finally, be able to apply tools to perform a risk analysis. This is a prospective tool. By way of brief introduction, I am an emergency physician by training and practice, and I will cover many of the clinical aspects of the presentation. Dr. Konara has a PhD in biotechnology and is an ISO certified lead auditor. As such, Chamindika will present the details on the retrospective and prospective tools. The agenda for today's meeting is, firstly, a brief introduction on patient safety, defining patient care, patient safety and patient treatment, explaining the link between patient safety and staff safety, and we will also present an overview of a systems-based approach to safety. This will include details and clinical cases on retrospective analysis and prospective analysis. Let's look at the current status on patient safety. Nearly 2.9 million people die in the USA each year. Up to 60% die in hospitals, 20% in nursing homes, and 20% in their own homes. The Institute of Medicine's To Err is Human report estimated annual preventable deaths to be between 44 and 98,000. This BMJ study from 2016 suggested that the number of hospital deaths from medical error was as high as 250,000 annually, making medical error the third leading cause of death in America. Estimates of the cost are as high as $17 billion annually. A 2020 systematic literature search by Yale School of Medicine reported only 22,000 annual deaths from medical error. So let's assume that the correct number lies somewhere in the middle. That number is still very high, and this talk aims to share with you what we can do to address this and make hospitals safer for staff and for patients. Why are preventable adverse events still occurring at this scale? James Reason, a British psychologist, very quickly stated the obvious. Doctors and nurses don't go to work to deliberately hurt or kill patients. So something else must be happening. He explained that what was going on was a series of systems errors and used the Swiss cheese model to explain this. I'm sure that some of you have heard the case that he used to explain this model, but let me paraphrase a bit in the interest of time. A 22-year-old young man was in hospital in the UK. He had leukemia with cerebral metastases. The metastases were causing agonising headaches. This young man had an IV cannula in his forearm for chemotherapy and a cannula into his CSF for more powerful pain relief. Sunday morning at 8 a.m, the new intern came up to the patient and said hello. He introduced himself and explained what he was going to do. But by accident, he injected the chemotherapy into the wrong cannula. It went into the CSF, the patient fitted and died. Why did this happen? The charge nurse was acting up as the aide-on, the ward pharmacist was on holidays, and her replacement had little or no experience with chemotherapy. The doctor was an intern, as such very inexperienced. And it was Sunday, so there was less staff around. Each one of these issues is represented by a piece of Swiss cheese. And if any one of these 4 issues had not occurred, that is, one of the holes had been plugged up, the mistake would have been picked up and prevented. The patient would not have died from a preventable adverse event. As alluded to before, the Institute of Medicine published its To Err is Human seminal report in 1999. They reported that between 44,000 and 98,000 medical deaths in US hospitals each year resulted from a preventable medical error. This report proposed a number of changes to healthcare delivery in hospitals to improve patient safety. In line with James Reason's work, the Institute of Medicine emphasised fixing the systems issues by creating a culture where individual clinicians were not assigned personal blame when errors occurred, and where preventable errors are reported so that they can be addressed to prevent future adverse events. Their recommendations included establishing a National Patient Safety Centre, implementing periodic re-examination and licensing, the use of proven medication safety practices, the design and use of comprehensive reporting systems, and team training programs focused on patient safety. Healthcare systems and governments worldwide announced that they would stop preventable adverse events from occurring. Unfortunately, all that money and other resources did not achieve the improvements we were wanting and expecting. In 2009, Dr. Carolyn Clancy, Director of the Agency for Healthcare Research and Quality, published the 10-year review in which she found that patient safety was actually getting worse in most areas. The 15-year review showed some improvement. The 20-year review highlighted some specific improvements, such as Dr. Peter Provenos's work in Keystone, Michigan, to reduce the complication rate from central line insertion. Obviously, this is not a very good report card. What are the reasons that could explain these bad grades? These 3 critical factors have been missed or undervalued, and this has contributed to the current situation in which patients continue to suffer from avoidable medical errors. Firstly, at times, the subtle but important difference between patient care, patient treatment, and patient safety is poorly understood. In 1999, the authors of To Err is Human report noted the importance of staff safety, albeit briefly in one paragraph on page 24, but they stated that staff safety would improve as a consequence of improving patient safety. Time has shown this not to be the case. Thirdly, all too often, root cause analyses have been ineffective as they have focused on people rather than focusing on the systems, as was confirmed in a 2016 BMJ review on how hospitals implemented and continue to conduct root cause analyses after adverse events. Let's go through how each of these missing pieces can be addressed, starting with a review on patient care, patient treatment, and patient safety. This table summarises a paper published in 2017. Patient treatment is defined as the treatment that the patient actually receives. It is individual or person focused. It's an active doing task. It is a towards task that it is being done to achieve a good outcome. It is aiming to do the most good for that patient. Examples include diagnostic tests and therapeutic endeavours to the individual patient. On the other hand, patient safety is defined as the background safety net in which all the patients, for example on a particular ward, are being treated. By contrast, it is system or process focused, often an inactive or avoiding task. It is an away goal, that is, it is being done to avoid a bad outcome. It is aiming to ensure the least harm is suffered by all the patients. Examples include corrective and preventative endeavours to keep all the patients safe. When this paper was originally published, it was felt that patient treatment was more the purview of medical staff and patient safety was the purview of nursing staff. However, I now don't think that this arbitrary distinction is accurate. The best patient treatment, and the best patient safety is achieved by a team effort. To explain this new concept, the Venn diagram model was developed. The green circle refers to patient treatment and the blue circle refers to patient safety. The combination of the two refers to the overall patient care delivered. In the ideal world, each patient receives perfect patient treatment and perfect patient safety. However, this is a practical impossibility. What we see in clinical practice is a bit of friction between the two concepts, a bit of friction between treatment and safety, a bit like between sensitivity and specificity. Even with the best tests, you get to the point where if you want a test to be more sensitive, you have to sacrifice a bit of specificity. The reverse is also true. If you tinker with a test to maximise its specificity, there will be a drop-off in its sensitivity. In the example on the left, when you are individualising a patient's treatment, this might include taking on an extra calculated risk. If the same risk were taken blindly across all the patients, some would be expected to suffer harm or a side effect. That is, some would have their safety compromised. An example would be organising a contrast CT scan on a patient with a slightly elevated creatinine. The green plus is the benefit to the individual patient having the CT scan. The blue minus sign is the possible harm being risked. The reverse is also true, as you can see in the example on the right side of the slide. Patient safety guidelines often state that patients with an elevated creatinine should not have a contrast CT scan. If this blanket rule is followed, none of the patients will suffer harm, in this case kidney failure, from the contrast. But an individual patient may have their diagnosis delayed or completely missed. The blue plus is no CT scan and no renal failure. The green minus is the possible serious diagnosis being missed. Understanding this distinction is important for many reasons. For example, a better understanding of these two concepts enables better understandings of alternative belief systems and clearer communications between people in the two different groups. It promotes more productive teamwork, and the patient will always benefit from this. Now that we have a background on the issue from the patient side, we're going to address how staff and patient safety are linked. To start this section, we will ask you to vote on our first polling question. In your facility, how much importance do you think is placed on staff safety by staff and management? Please reflect on this question and note your answer. The Public Citizen's seminal report on staff safety in healthcare compared occupational injuries and assaults in hospitals with the incidents in manufacturing and construction industries. They concluded that healthcare was a high hazard industry. Who would have thought that we suffer around 7 times as many musculoskeletal injuries as they do in a construction site? And who would have thought that we suffer around 7 times more assaults than they do in construction? Stop and think again. Yes, that could be right. I think our failure to recognise this is explained as a normalisation of deviance. If you work in an emergency department, you expect to be abused by the drunk patients. If you nurse obese patients on the ward, you expect to hurt your back when one of them falls and you try to save them. It just becomes normal for you. The paradox of blameworthiness describes the current situation in many healthcare facilities whereby staff are instructed to operate in a no-blame culture and report incidences involving compromised patient safety, but staff are allowed to continue to operate in a blameworthy culture in relation to incidents involving their own safety when it is compromised. It is not possible for anyone to operate in two diametrically opposite mindsets at the same time. As a result, both patients and staff suffer preventable harm. The impact on patient safety is becoming clearer, and this was highlighted by the COVID-19 pandemic. Staff safety was compromised because of the lack of access to appropriate PPE. This led to an increased chance of COVID infection passing from staff to their patients and vice versa. The inexplicable increase in violence against healthcare workers, combined with employee sick leave and furlough, reduced staffing levels that in turn had a deleterious effect on patient care. The psychological distress and exhaustion that increased during the pandemic has led to a decline in performance, resulting in increased patient safety risks. This Lancet article summarises the situation perfectly. There now needs to be universal recognition that health worker safety is patient safety. One cannot exist without the other. I'll now hand over to Chamindika to shed some light on systems-based approaches to safety.
Now that Michael has looked at the history of patient safety and sadly the fact that the improvements implemented to date have not achieved what was intended, let's see what we can all do differently to improve safety in healthcare and better outcomes for the patients you care so much about, and as importantly, safety of your colleagues and yourselves. We will first go through a summary of the theoretical framework to a systems-based approach to safety, followed by case studies on how this framework can be implemented in practice. Adverse events are not all bad. This sounds a bit controversial, doesn't it? But adverse events provide clinical and management teams with important information on what needs to change to make things better. On an average day in the US, well-trained and dedicated healthcare providers care for close to 100,000 inpatients. For the overwhelming majority of these patients, this care is delivered safely and effectively. It is important to acknowledge, however, that despite the best intentions of healthcare providers, doctors, nurses, midwives, and allied health, things occasionally do go wrong. Patients are aware that adverse events happen, as these are the stories that receive heavy media attention. What patients and the general public want to know is what is being done about it. Adverse events cause physical and emotional harm to patients, their families, and to hospital staff involved in the event. This also generates a significant social and financial burden. We should not be preoccupied with simply counting adverse event reports. Instead, we have to find ways to effectively and proactively manage them. Michael and I hope by the end of this session, you will look at adverse events differently. You will see them as real opportunities to improve healthcare systems, and you will have the tools to do this. So let's start with defining what we are looking at. A system is a set of policies, processes, and procedures designed around people and equipment required for planning and execution of core functions of an organization. Systems can be generally classified into two categories: mechanical, example instruments and devices, or adaptive, example organisms or organizations. Mechanical systems have a higher degree of predictability and are easier to control because they respond consistently to the same stimulus. Adaptive systems have a low degree of predictability because all parts of the system do not respond in the same way to the same stimulus. Historically, when an adverse event occurred, the tendency was to look for the most obvious explanation of what and why it happened. In most cases, individual human error was identified as the cause, primarily because it was easy to identify and appeared to be easy to fix. This approach ignored the underlying contributing factors that led to the incident and thus presented a shallow analysis of circumstances. The outcome of such an analysis may have included additional training, disciplinary actions, and/or expectations of increased personal vigilance. The focus was almost exclusively directed at improving individual performance, and as a result, this approach was unsuccessful in preventing the same or similar incident from occurring again. It became apparent, especially within industries outside of healthcare, that it is important to have a systems approach to incident management and review what underlying factors within system contributes to human behavior. A systems-based approach has some inherent advantages to the historical human error-based approach. It acknowledges facts of life, that is, universal nature of humans to falter and the inevitability of error. Errors will always occur. By acknowledging this, we can design a structured way to review and improve the systems in place to reduce the likelihood of these errors and, more importantly, the consequences. I will go through some basic principles of a systems-based approach. First and foremost, it is not a blame game. We are not trying to find someone to assign the problem with. It is also important to realize that this is not just looking for an immediate fix. To be able to address the problem, one has to have an open mind to dig deeper than the surface issues. We need to establish a sequence of events or a timeline to understand what happened and consider that there may be a number of contributory factors that result in a particular problem. Often, there are more than one cause leading to the problem, so it's important that you continue to keep digging to find all the different causes that led to this issue. If there is one thing I would like you all to remember from this list, it would be not to end the analysis at symptomatic causes such as human errors. Systems-based approach is also very much a team effort, and it is also important to verify the accuracy of your findings. As we go through the rest of this session, these principles will become more apparent. In order to prevent adverse events, there are two key perspectives that must be addressed by facilities. First, a retrospective view, which is after an adverse event has occurred in your healthcare facility. Second, a prospective view, which is before an adverse event has occurred, but you have identified a potential adverse event. Both retrospective and prospective analysis offer opportunities to learn and improve current systems. We will start with a more detailed look at how the retrospective analysis can be done so that we can manage adverse events using a systematic approach. Retrospective analysis uses two different tools: root cause analysis as the analysis tool, corrective and preventive action framework, or commonly known as CAPA framework, is used as the tool for implementing solutions to address the adverse event. So what is a root cause? Root cause is defined as the original source of the problem and usually is not obvious when the problem occurs. When we often see what a problem or adverse event occurs are the symptoms of the problem within the system. Root cause analysis helps to identify why repetitive human errors or equipment failures are associated with specific processes, which lead to subpar performances and adverse events. Within industries outside of healthcare, human errors are considered symptoms of the problem. Healthcare is also slowly adopting this process, with patient safety experts now strongly advocating a way of thinking that views human errors as symptoms of broader issues within a poorly designed system. I want you to have a moment to think about why it is important to determine the root causes. Root cause analysis usually leads to design improvements in the work process and equipment that accommodate both human capabilities and limitations. These design improvements also make sure that not only one individual but the entire team can perform better. If the root causes are addressed effectively, it decreases the likelihood of problems recurring and similar errors from occurring. As a result, patient treatment, care, and satisfaction improve. In addition to the obvious benefit of preventing patient harm, this ultimately saves money for the healthcare facility and payer by decreasing the direct cost associated with adverse events and creating a workplace culture that retains staff. These are some of the tools used for conducting root cause analysis. Today, I will go through the first 4 of them with you: 5 whys, Ishikawa or fishbone diagram, tree diagram, and Pareto analysis. These are the 4 most used tools. Brainstorming and flowcharts or process mapping can also be incorporated as part of the root cause analysis and are quite self-explanatory. We will also go through patient and staff case studies to put these tools to practice. As the name suggests, using the 5 whys approach means repeatedly asking the question why, so you can peel away the layers of symptoms to lead to the root cause of the problem. It is helpful in tracing a chain of events, starting with adverse event and working backwards. Although this technique is called 5 whys, you may find that you will need to ask the question fewer or more times than 5 before you find the issue related to a problem. 5 is used as an arbitrary number to remind you to dig deeper into the problem and get past the surface explanation. Moving on to fishbone diagram, also known as cause and effect diagram or Ishikawa diagram, it is used to graphically identify and organize all of the contributing root causes of a problem. The fishbone approach helps focus problem solving and reduce subjective decision making. It is particularly useful when the analysis is done in a group setting, such as in M&M meetings. It works in situations where there is very little quantitative data available for analysis. It's also great when there is a need to display and explore many possible causes of a specific problem. How do we use the fishbone or Ishikawa diagram? You start on the right with the effect or the problem. It is specifically designed in this orientation of right to left so that from early on you recognize that the effect or problem you see on the surface has an underlying cause or causes. Once you have placed the problem statement at the head of the fish, the rest of the fishbone diagram then consists of one line drawn across the page and several lines or bones coming out vertically from the main line. You label the bones coming out by identifying what are the different contributing factors. Once the bones are labeled, begin brainstorming possible causes and attach them to the branches. For each cause identified, continue to ask, why does that happen? This will help you get to the true drivers of the problem. The tree diagram is another visual tool for analysis of problem identification of symptoms and causes. As with the tree, there are 3 parts: branches, trunk, and the roots. The branches represent the effects or the symptoms of the problem. The trunk is the problem statement. The roots represent the causes of the problem. This guides us to break down to finer levels of details prior to identifying further actions. Developing the tree diagram also helps to move thinking from generalities to specifics. Pareto diagrams are useful for root cause analysis when you have quantitative data. It is based on statistical analysis that relies on the 80-20 rule. That is, 80% of the effects of the problem come from 20% of the causes. In a Pareto diagram, the height of each bar represents the quantity of the problem. You identify where 80% of your problems are and usually use another tool such as 5 whys, fishbone diagram, or brainstorming to identify root causes and further actions. Let's now pause for a minute for the second polling question. We would be interested to know which of the tools for root cause analysis that we have discussed have you been trained to use. Once you have done the root cause analysis and identified the causes that resulted in an adverse event, the next step is to recognize and implement solutions. To do this, we use corrective and preventive action framework. It is really important at this stage to distinguish the differences between correction actions, corrective actions, and preventive actions. Correction actions eliminate the immediate problem. It doesn't eliminate the issues permanently, but allows a process or work to continue. If we look at a simple example of a problem where there is water leak from the tap, the correction action is to mop up the water and add a bucket under the leak so that it removes the hazard and allows the process to continue safely for people to use the tap without flooding the room. Corrective actions eliminate the cause of the problem or adverse event and prevents repetition. So with the leaking tap, one should investigate the sink, the drain, and the water supply system. This is the root cause analysis. Let's say we identify that there is a broken washer in the tap causing the leak. Replacing the washer is the corrective action. Preventive actions prevent potential occurrences of similar issues. Preventive actions try to address issues before they happen. So in the case of the sink, we can develop a maintenance schedule to review the water supply system in all sinks. This maintenance schedule should include a checklist that addresses the water supply system, including the washers, and provide training for the relevant personnel. As we go through the case studies, keep in mind this distinction between correction, corrective, and preventive actions. When we look at the CAPA framework for implementing solutions for a root cause, it often requires changes to existing systems or processes, or implementation of new systems or processes. So it is important to recognize that this requires commitment in terms of resources and time. Finally, the effectiveness of CAPA should always be audited. This is to ensure that the actions that have been taken to fix the problem and prevent future problems are actually effective. Some common examples of effectiveness checks are looking into how many similar adverse events have occurred over a period of time. The lower the number, the more effective, or conducting a trend analysis over a defined period of time with minimum acceptance criteria. Let's now go through some case studies to see how we can implement retrospective analysis for patient and staff safety incidents. We are starting off with the patient safety case study. This particular case study hits close to home for me, not only because this happened in Perth, Australia, but similar to the patient in the case study, I was also pregnant with my first baby at the time. Mrs. SH was a young mother to be in Perth. She lapsed into a coma after being given 100 milligrams of morphine instead of just 10 milligrams, which would be the maximum routine dose during labor. Mrs. SH was rushed to the ICU after lapsing into a coma, but unfortunately her baby died. Up until this medical error, Mrs. SH was having an uncomplicated pregnancy. The hospital in Perth concluded their investigation with the following outcome that we have quoted here. It was a tragic occurrence caused by human error. One midwife was suspended while another staff member handed in their resignation. Before we get into the tools, I want you to have a think about what you think should have happened in this case. Does suspending the midwife make sure that this type of medical error doesn't reoccur? How can we manage this adverse event using a systems-based approach? Yes, a human error did occur, but is this the true root cause? I think it is clear to you and I, human error in this case is a symptom of a broader issue within a poorly designed system. So let's see if the outcomes of this investigation differs if we take a systems-based approach. We started this process with 5 whys, as 5 whys is a good starting point for any retrospective analysis. However, we quickly realized there are a number of contributing systems or processes, so we moved on to a fishbone diagram. As the first step, we defined the problem. Then we used brainstorming exercise to identify the bones. The different systems or processes involved are the prescribing system, the dispensing system, the drug administering process, and the patient monitoring process. Let's start with the prescribing system. The patient was wrongly prescribed 100 milligrams of morphine instead of 10 milligrams. When this happened, the electronic prescribing system didn't flag that this is 10 times the standard dose. The prescription was then dispensed. The healthcare provider dispensing the prescription was not alerted by the system that this is 10 times the standard dose per patient. The double check carried out prior to administering the drug to the patient didn't recognize this as 10 times the dose as well. Why? The double check relies on the experience of the person who's doing the check. It is likely that there were no drug dosage charts or visual aids in the maternity ward to assist with this process. Finally, the patient monitoring has failed as well. It was only the next morning that the care team identified Mrs. SH was in a coma. Her husband thought she was sleeping. Mrs. SH's deteriorating conditions were missed during routine inspections till next morning. It is likely the routine respiratory rate measures were not carried out as the midwife was too busy with other patients. What she observed when she saw the patient sleeping is what she is expected to see after the correct dose of morphine administration. Why did this happen? Likely due to poor staffing ratios. It has recently been reported that this particular hospital in fact have poor staffing ratios, leading to a number of other issues as well. Based on this analysis, we can identify 4 root causes which contributed to this error. 1. Prescribing system didn't flag that this is 10 times the standard dose. 2. Dispensing system didn't flag that this is 10 times the standard dose and 10 ampules, not the expected single ampule. 3. Double check relies on experience and there was absence of drug dosage chart or visual cues in the ward. 4. Poor staffing ratios. Now think about the report from the hospital investigation. Tragic occurrence caused by human error versus the causes identified by this systems-based approach. You can see that an opportunity to learn and improve was missed by focusing only on individual behavior by the hospital rather than a systems-based approach. Nothing in the hospital's approach prevents this from happening in the future. Let's now look at correction, corrective and preventive actions that can be taken to address these root causes we have identified. For root causes 1 and 2, correction actions include to treat the patient's overdose and to see whether the staff involved require support such as counseling. For root causes 1 and 2, potential corrective actions include incorporating alerts in the electronic prescribing system and the dispensing system when opioid dosage is over standard limit, or even to have a standard dosage per patient included as a line item in the system. Once the system upgrades are done, it's important to provide training on these upgrades to the relevant staff. There are also potential preventive actions that can be taken to prevent occurrences of similar incidents in the future. For example, comparing and contrasting processes in other wards when it comes to safe opioid use or other similar drug categories. Compare birthing suites to ED to the theatre. For root causes 3 and 4, correction actions are the same as before. That is, 1. To treat the patient's overdose and 2. To see whether the staff involved require support. As a corrective action for root cause 3, we can add an opioid max dosage chart or simple signage at PrEP stations in maternity wards. No more than 1 ampule per patient is a good rule of thumb, instead of relying only on the experience of relevant staff members. As with before, any such changes should be complemented with necessary training. Corrective actions for root cause 4 is to review staffing ratios in the maternity ward. The preventive actions for both root causes include compare and contrast processes in other wards when it comes to opioid or other similar drug categories. As with before, compare birthing suites to the ED to the theatre, as well as revising staffing ratios for other departments and wards. Remember, this work is not useful if we do not verify the effectiveness of the correction, corrective and preventive actions taken. To measure the effectiveness of these CARPA actions, we can aim for absence of similar adverse events or minimum threshold levels for similar incidents as an effectiveness audit. We can also spot audit to ensure the processes in place are being adhered to. This is not to identify whether individuals are faltering or not adhering to processes, but rather to see whether the new processes are simple and fit within standard behavior and work processes of teams. The effectiveness check can be done after a period of 6 months or 1 year, depending on the frequency of such dose administrations. Now let's look at how we can use retrospective analysis for a staff safety case study. A 24-year-old female nurse had a penetrating injury to her right wrist while she was disconnecting the scalpel blade from its holder. She was holding the blade holder by her left hand, trying to disconnect it by an artery forceps with the right hand when the blade slipped and penetrated the medial aspect of her right wrist, resulting in severe pain and pulsatile bleeding. On examination, there was a linear cut to the medial aspect of the wrist, resulting in total transection of the ulnar artery. Immediately under local anesthesia, the artery was ligated. Scalpels are second only to suture needles for the likelihood of a sharps injury in the OR. We conducted a 5-why root cause analysis on this case study. Why did this injury occur? First, the nurse was holding the scalpel handle in the left hand. The blade slipped, resulting in injury in the right wrist. Why? The scalpel blade slipped from the grip of the artery forceps, injuring the nurse. Why did the blade slip? artery forceps are not designed to remove scalpel blade from scalpel handles safely, resulting in user errors. Why were artery forceps used? It is likely that safety devices designed specifically for removal of scalpel blades to prevent such user errors were not provided. It is important to note here that it would have been very easy to stop this analysis at Y2 and focus further CAPA activities on errors associated with the use of artery forceps by that particular staff member, such as training. Again, this would mean stopping the root cause analysis prematurely and leading to ineffective CAPA activities. We need to ask ourselves whether providing additional training to that staff member will prevent similar injuries happening to other staff members. Let's now look at correction, corrective and preventive actions for the identified root cause. Correction action is to provide safety devices designed specifically for the removal of scalpel blades, with features such as single-handed usage, keeping the blade enclosed once removed, and passive or automatic activation. Corrective actions include adding scalpel blade removal devices designed specifically for this purpose as part of procedure packs or equipment setup checklist to ensure standardized usage. Secondly, providing training for the staff on the correct usage of new scalpel blade removers. Possible preventive actions to address this root cause include reviewing or journey mapping usage of other sharps devices and implementing similar safety programs that include safety devices, training, changes to existing SOPs or new SOPs. Providing training to the staff on the correct usage of new safety devices, reviewing procurement processes. The next step is to verify the effectiveness of these CAPA actions. These include monitoring the absence of similar sharps injuries or trend analysis with minimum acceptance criteria, spot audits to ensure that the updated or new processes in place are being adhered to, reviewing participation of staff in training programs, comparing purchase data of sharps devices to purchases of related safety devices. And for this particular case study, it is important to note that most sharps safety policies now require exposure plans or sharps policies to be reviewed regularly. In the US, OSHA regulations now require exposure plans and sharp safety control measures to be reviewed annually. I want to highlight some of the common errors that happen when we adopt a systems-based approach. I think you're all well aware of some of them by now. These include ending analysis at a symptomatic stage, assigning root cause of the problem as the Y event that preceded the actual root cause, looking at a single cause, identifying only correction actions and not including corrective and preventive actions, and not conducting an effectiveness audit. This is a quick summary of quality systems based retrospective analysis. We start with the adverse event, then you initiate root cause analysis, which will then lead to identifying root causes and correction, corrective and preventive actions. We then implement these CAPAs and have a plan to verify the effectiveness after a certain period of time. If the effectiveness audit is unsuccessful, we start the process again with root cause analysis to see why the effectiveness audit failed and go through the process. If the effectiveness audit is successful, we can close this particular case and keep the records for future reference. I will now hand back to Michael for the next section of this presentation.
Chamindika has explained how patient safety and staff safety can be improved by thoroughly examining an incident after it has occurred to determine the actual cause or causes, developing strategies to prevent a recurrence of this incident, and using CAPA to ensure the solutions are implemented. Now we will look at how prospective analysis can also be used to improve patient safety and staff safety. The tools include hazard risk analysis to determine what hazards are present and what harm they could cause, and then the hierarchy of controls framework to implement the strategies to prevent these predicted hazards leading to adverse events. To conduct a hazard risk analysis, firstly identify the hazard. a hazard is something that can cause harm to someone. Then, use the risk matrix to find out the level of risk the hazard poses. You determine the risk level based on 1. The likelihood of that hazard causing harm, and 2. How severe the impact would be should the hazard cause harm. Most facilities will have a procedure for exactly how the likelihood and impact can be calculated. As a quick example, when assessing the risk of a patient fall, the likelihood may be based on the number of falls which occurred at a similar facility in the previous year, and the impact would be ranked on how severe the potential injury would be to the facility's average patient. Once the hazard risk level is identified, the hierarchy of control can be used to effectively implement strategies to prevent the hazard causing adverse events. The higher the risk category, the more important the control measures are. The hierarchy of controls provides us with the necessary framework to identify where more effective control measures can be implemented in hospitals, ensuring the systematic prevention of potential adverse events. The hierarchy of controls dates back to the 1950s when they were developed by the National Safety Council in America. They took an upside-down approach to the behaviour-based safety programs that ignored hazards and risks and focused on critical workers' behaviour. The old way of dealing with staff safety relied heavily on elaborate mechanisms to check, inspect, observe, coach, reward, and even discipline workers. Does that still ring a bell? Over the last 70 years, the hierarchy of controls has been standardised across most industries to reduce risk in a systematic, system-wide manner. Healthcare is finally reviewing and adopting this proven approach. Use of the hierarchy of controls is now recommended by many globally respected institutions in healthcare, including but not limited to the World Health Organization, the Centre for Disease Control, the National Institute of Occupational Safety and Health, and AORN in the US, to name but a few. The hierarchy of controls is divided into 5 levels: elimination, substitution, engineering controls, administrative controls, and personal protective equipment, or PPE. It provides you with a structured and simple way to manage hazards to patients and to staff. Elimination is the removal of the hazard. This is obviously the best way to prevent a bad outcome. Substitution is the replacement of the hazard with a safer alternative. Engineering controls are designed to further protect people from hazards by creating a change to the worker's environment. Administrative controls ensure that staff changes the way they work and that implementation of the control measures is successful. Personal protective equipment is the last line of defence to protect staff from hazards. To illustrate how prospective analysis can be utilised in clinical practice, we will look at case studies, one pertaining to patient safety and one to staff safety. Again, we'll start with patient safety. Patient falls are common and dangerous. In the USA, it is estimated that between 700,000 and 1 million patients fall while they are inpatients in hospitals each year. And over 1/3 of these patient falls result in an injury, commonly a head injury or an orthopaedic injury. I invite you to use the risk analysis matrix to determine the risk of patient falls in your facility. Please make a note of your answer. The hierarchy of controls is an excellent framework that can assist with the implementation of strategies to minimise both the likelihood and the impact of patient falls caused by common hazards in a facility. Elimination or removal of the hazard is the best way of protecting patients from falling. This involves removing trip and slip hazards, for example a loose rug in the home or hospital. Substitution or replacement of the hazard with a safer alternative is the next most effective way to prevent the patient falling. Examples of this include replacing old floor tiles with non-slip tiles, especially in wet areas such as bathrooms and laundries. Engineering controls, such as the installation of grab rails and stair lifts, can be looked at to further change the patient's environment to prevent this hazard and the risk of a fall. The next step is administrative controls. Administrative control measures for preventing patient falls could include writing a fall prevention plan with your at-risk patients and their carers, and then translating these policies as needed. Training the staff as well as the carers on how to implement the fall prevention plan, and using signs such as slip hazards after a floor has been mopped. In summary, the administrative controls are a good way of ensuring that the higher levels of controls in the hierarchy are being implemented. PPE sits at the bottom of the upside down pyramid for a reason. It is the least effective way of dealing with a hazard. It can be thought of as a last resort. Examples of PPE for patients who are likely to fall include hip protectors to reduce hip fractures when the patient falls. Would you prefer for your grandmother to have her fall prevented entirely, or to have her hip protected from serious fractures after the fall? The same process can be utilised to reduce risks for staff safety as well. This means we only need to learn and practice one, not two sets of tools to improve safety across the hospital. To illustrate this clearly, we will use the case study relating to a sharps injury. Like patient falls, sharps injuries to staff are very common. An estimated 385,000 sharps injuries occur in US hospitals each year, and this figure is an underestimate as 50% of sharps injuries go unreported. Remember the blameworthy paradox. The risk of a staff member being infected with a bloodborne pathogen after suffering a sharps injury involving an infected patient is incredibly high. 1 in 3 for hepatitis B. Fortunately, this risk has been more or less eliminated by vaccination of all healthcare staff. 1 in 30 for hepatitis C and 1 in 300 for HIV. Elimination is obviously the best way of reducing sharps injuries when it is a possibility. By way of examples, non-essential intravenous and intramuscular injections need to be stopped. The medications need to be given as oral or transdermal formulations as soon as is feasible. And for appropriate wounds, glue should be used in preference to sutures. Substitution can further reduce sharps injuries. Examples include the almost universal introduction of needle-free intravenous access systems and surgeons using blunt-tipped suture needles for closing muscle and fascia in surgery. However, in many cases, elimination or substitution of a sharp is not physically possible, such as the need for scalpels to be used in surgery. In these cases, we need to look at the next level in the hierarchy of controls to determine the best ways to prevent these injuries, starting with engineering controls. Engineering controls to prevent sharps injuries and cuts included devices that are specifically designed with a safety feature to protect the user from injury. An example would be a single-handed scalpel blade remover. By contrast, hemostats, Kelly grips, artery forceps and needle holders are not designed to safely remove scalpel blades. As the earlier case study Chamindika presented shows, despite their frequent use for this task, they are not considered to be an engineering control and should not be used. Other examples of engineering controls include retractable syringes and sharps disposal units that comply with relevant regulations and standards. By way of a quick update on this important topic, recent studies have shown that all safety devices used as engineering controls are not equal. According to these studies, safety devices can be categorised into two groups: the more effective passive or automatic safety devices and the less effective active or manually activated safety devices. The next step is administrative controls. Examples of administrative controls to support prevention of sharps injuries include writing policies, such as for sharps safety, hopefully referring to AORN's sharp safety guidelines. Standardising compliance with safe work practice, including routine use of hands-free passing techniques, banning recapping of syringes, and of course, obligatory routine sharps injury reporting. Ensuring staff are adequately trained in safe work practices and the use of the engineering controls. The training can now be done online with videos and with new interactive training apps. Also, implementation compliance can be monitored with safety score audits of purchasing data. Personal protective equipment or PPE. Examples of PPE for staff when handling sharps include double gloving and protective footwear. It's important for a facility to ensure the non-clinical staff exposed to sharps, for example laundry workers, are also given access to PPE. As we have seen before, despite PPE being the most universally identified way of keeping staff safe, PPE is the option of last resort, the last line of defence. The first 4 levels need to be given greater importance and need to be implemented in conjunction with PPE, not replaced by PPE, as is mentioned in the bloodborne pathogen standard under OSHA regulations. Using prospective analysis tools can improve safety across the board. However, they must be used correctly to be effective. The following errors are relatively common and include 1. Not actually conducting the prospective analysis in the first place. 2. Not identifying all hazards. For example, the all too common practice of simply ignoring staff safety issues. 3. Implementation being conducted ad hoc. Patient safety has been identified as a systems issue. Remember James Reason's Swiss cheese model. Therefore, implementation of a safety strategy should be done in a systematic way. The hierarchy of controls is a great tool for addressing this. 4. Relying on administrative and PPE controls at the expense of the higher levels of control is a recipe for disaster. And last but not least, 5. Not conducting an effectiveness audit. Without this, you can never be sure that you have achieved the desired outcomes. The steps involved in a successful prospective analysis to prevent adverse events include: firstly, the identification of the hazard. Next, determining who might be harmed and how this would happen. The risk analysis matrix can be used to prioritise which hazards need to be addressed first. Utilise the hierarchy of controls framework to implement control measures. Make a plan for how you will verify the effectiveness of the facility's control measures. And finally, the solution must be audited to confirm its effectiveness before going on to address the next hazard using the same systematic approach. We hope that today's session has helped equip you to improve both patient and staff safety. There has been a lot of work in this area over the past 20 years, but as we all have experienced, there is still a lot of work that can be done in our facilities to ensure that adverse events are systematically analysed instead of taking the easy route of blaming human errors. In summary, the tools for retrospective analysis of past adverse events and prospective analysis of potential adverse events can be utilised throughout the hospital and are applicable to all team members, clinical, managerial and auxiliary. Together we can achieve one safe culture for everyone, staff and patients. I expect this goal would have universal agreement and requires engagement across teams within hospitals and all workplaces. Before we move to our last polling question, Chamindika and I would like to thank you for your participation. Hopefully next year we will be able to be physically present. We would also like to thank Merrin Monteith, who did an enormous amount of work in preparing today's presentations and PowerPoint slides. Our last polling question is designed as a mini audit of the effectiveness of our presentation. Chamindika and I would like to learn whether you believe the retrospective analysis and prospective analysis tools could be utilised in your facility to improve staff and patient safety. Please choose from the following. We look forward to reading the answers to the polling questions that you have shared with us today.